Good morning, everybody. We're about ready to get started. I would like to introduce our speakers for this session, Dr. Leigh Atherton and Dr. Cheryl Meola. They will be presenting on their research with the main program, which is Minis, offering adolescents with addictions new experiences. So hope you all enjoy.
Okay, thank you for that introduction. We were told to speak directly into this microphone so that the recorder can pick it up. So if we don't, somebody just do a thing like this. I'm Dr. Cheryl Meola. I work in Greenville, North Carolina. We do some of our research over at a premier accredited center now in Greenville called Rocking Horse Ranch. And then I also have a private practice called Main Source Counseling where I see clients in psychotherapy. And then I participate in several research studies with Dr. Leigh Atherton.
Morning, everybody. You guys doing good? Everybody have some good breakfast? All right. My name is Leigh Atherton. I'm an assistant professor in the Department of Addictions and Rehabilitation Studies at East Carolina University in Greenville, North Carolina. In today's session, we're going to focus on some of the research that we've been doing out at Rocking Horse Ranch, which is the accredited. I've partnered with Cheryl and with the staff out at Rocking Horse Ranch. We have many different projects that we're doing out there, really looking at integrating equine-assisted therapy, equine-facilitated psychotherapy into mental health and addictions treatment. And this program, the main program, is the one that we're going to talk about today. Very exciting, really looking at how can we enhance the effect of addictions treatment, in particular for this project with adolescents with addiction, to kind of bolster the effect and try to really help improve basically the psychosocial well-being outcomes for individuals with addiction. So what we're going to do in terms of structures, we're going to go over relatively briefly the overview of the project, what it looks like, why we chose EFP in particular for this study, how it connects to both addiction treatment or theories of addictions treatment, as well as some of the benefits that equine facilitated psychotherapy brings to that. And then we'll get into talking more specifically about our study, looking at the research design. I know the research is obviously very important. My guess is you guys probably want to hear more about what we actually did, what the intervention looked like. So we're going to go a little bit briefly over the design, the methods, but really spend a lot of good time on here's what the intervention looked like, and here's some of the responses of that. Then we'll wrap up with the results of our study, looking at limitations, future directions, as well as implications for both path-accredited centers, equine-assisted interventions in general, and then obviously addictions treatment, and then we'll open it up for questions. Sound good? All right. I was going to say, I can't change it, so that's what it's going to be. So the main program, excuse me, is a partnership with a local adolescent inpatient or residential adolescent treatment program. ECU looking at the research side of things, and then Rocking Horse Ranch, which is the PATH Premier accredited facility, looking at how can we use those community partnerships to form and try to improve the services that are being offered for the adolescents in our community and our county. And essentially what we looked at was how is treatment as usual being done at the residential treatment program. And that treatment was primarily tied to what's called choice theory or reality therapy. And they have 7 healthy habits, and we developed a program, an EFP integrated program, looking at connecting equine activities to those 7 habits. And we actually chose 6 because there's one that would kind of spread across all the rest of them. But we chose 6 to develop our 6 sessions, and we'll get deeper into what those look like as we go on. And sorry, we're waiting on it. The problem, kind of why we did this, why we were looking at this integration, is thinking of addictions treatment in general. Right now, we're sitting at maybe 35 to 40% success rate in terms of recovery or preventing relapse. We're doing well given the nature of addiction, but we need to improve. Obviously, we need to get better. We need to really look at what can we do with the interventions that we're using to improve the outcomes. And equine-assisted therapy, equine-facilitated psychotherapy we looked at as one way to bolster the effect, to enhance the effect as an adjunctive therapy to really help solidify some of the treatment that's going on. Specifically for adolescents, anybody work with adolescents in some form or fashion? I guess is majority. In office-based treatment, even residential treatment, it's very difficult to keep them engaged. It's very hard for them to, depending on the age, some of the techniques, some of the strategies we use can be a little bit abstract. So it's not able to really make that connection from, here's what we're talking about, what does that mean for me practically? What does that mean for me in real life? How do I change my behavior based off that? So one of the benefits of, let me go ahead and click that, thanks. One of the benefits of the integration is, as I'm sure preaching to the choir in this room, the use of horses or animals in general helps to engage. Adolescents, kids, they love the horses, especially the miniature horses. Not many of them have actually seen miniature horses, so it's been a way to draw them into the treatment. Awesome, thank you. To draw them into treatment and help them engage. And also looking at practical or transferable or transference of knowledge, right, or skills. Being able to practice basically in a role play or in a real play, practice this idea of being able to connect, being able to work together, being able to negotiate differences. We'll go over, again, the 6 themes that we focused on. But being able to do those things through activities and with their peers and really cement the ideas and the behaviors that we're looking at. Right? So more engagement, looking at, more excited about engaging in the treatment process, and then being able to kind of see firsthand the behavior change coming out as opposed to doing it more verbally, which we do in counseling, and trying to apply that themselves in the real world. So that's essentially the thrust of what we wanted to look at is, does equine-facilitated psychotherapy help to enhance the overall treatment, enhance the skill development, if you will, of the adolescents involved in the substance abuse treatment?
Sometimes they give you tools and they don't work.
So the choice theory in reality therapy, which is the therapeutic intervention based off of choice theory, has many different parts. Essentially, the main kind of thrust of it, or the underlying assumptions, is basically looking at people or humans are motivated, and motivation is deliberate. Right? So instead of, there's different models and different strategies, it's different drives that are doing us from a psychodynamic approach or from a cognitive approach, different thoughts that come up that drive behavior. From a choice theory or reality therapy approach, it's that we as individuals make our decisions, we choose, and our motivation for that behavior is deliberate and chosen. Okay? So that seemed to work real well in that the activities that we would do, that we would really help the individuals make those choices, right, and think through the different choices that they had to make. And within addiction, that's a big part of recovery, is do I pick up again, do I engage in these old behaviors that led to me using, or do I make different choices that lead to different behaviors, i.e. recovery, not using? And on the list here, it's from a choice theory perspective, they have 7 healthy habits, 7 deadly habits. Right? And obviously in treatment, we focus on the positive side, so we focus on the healthy habits, and they include supporting, encouraging, listening, accepting, trusting, respecting, and negotiating differences. Accepting was one that we saw kind of went across the board, so we didn't include that as part of our intervention in our session development. We included that within each of the sessions. So this pretty much created the framework for what our intervention protocol looked like and kind of where we came from and the skills that we're trying to enhance with the adolescents that we worked with.
Okay, so I'm going to talk a little bit about how we saw all these problems, saw a solution that might work, and then put it all together. So we set this up as an exploratory study since there aren't a lot that have been done previously in the field. We started off with a cohort of 5 adolescents at a time. They come for 6 EFP sessions. Each session is an hour and a half long, so they spend an hour doing an intervention with the horses and then a half-hour processing in a group setting. It's a mixed methods research design, so we give pre and post assessments. We have 3 quantitative assessments. There's self-assessments right now that they take at the first session, and then again at the last session upon completing the last session. And then we have weekly journals. We've set up a journal that talks to them about what they're going to learn each week, and then at the end is a section with a question to complete based on the activity. Our plan is in the future to do a content analysis of this as part of our research. We haven't done that yet, but we have looked at them and just kind of anecdotally analyzed them. But that's going to be further along as we get more cohorts going. Okay, so the intervention design. What we did is, like Dr. Atherton said, is we took 6 of the 7 habits and we developed a curriculum that focused on one of those habits each week in this order: listening, trusting, supporting, encouraging, respecting, and then negotiating differences. For staff in the intervention, we have an equine specialist who is there to make sure that the horses are, their needs are met and that they're appropriate for what's going on. We have a therapist who's there to make sure that the client's needs are met and that everything's appropriate for them. And then we have a horse trainer who explains the activities and the skills to the clients. For horse choice, we originally thought of this program as doing it exclusively with the minis, hence the name. But we have, when we decided to do a larger group, we have expanded it so there are big horses and little horses in the program right now. And then the research questions that we're focusing on right now are: how does the 6-week, 1.5-hour EFP group, which is equine facilitated psychotherapy, influence behaviors around the 6 habits in adolescents living in a residential substance use treatment facility? So we're looking at behaviors. We're looking at how the group influences depressive symptoms in this population, and then we are also looking at how it influences anxiety symptoms in this population. So we'll keep these in mind as we go along into everything else. Yes.
Thank you. So in looking at the demographic makeup of the population that we served, again, we've had 2 cohorts go through, so 10 people as of now. Therefore, kind of the disclaimer of 10 is good, but that's still a small sample size, so all the data that we have is more trend in direction versus actually making correlational statements or conclusive statements, again, since we have such a low number. But what our group has looked like is a pretty diverse group. We had 60% male, so 6 males, 4 females. 50% were African American, 37%, so 5 were African American, 4 were Caucasian, and 1 identified as biracial. And our age range between 14 and 17. And we had a pretty fair mix within that, basically 3 14, 3 15, 3 16, 1 17-year-old. And something that we asked, we did not analyze this for this presentation, but we do want to probably go back and look at this a little bit deeper. We asked if they had experience with pets. Basically, do you have a pet in the family? And if you do, what kind of pet is that? And the reason why we asked that question is, part of the research is looking at the outcomes. Does it reduce psychosocial symptoms? Does it improve behavior? But we also, a big part, kind of the big picture, one of the things or areas that we're continuously looking at with animal-assisted interventions in general, not just with horses, is what is the actual role of the animal and how does that connection work? And part of that discussion, part of that research will be, do they have experience with animals? And does that help to mediate that connection or foster that, the strength of the animal versus those that aren't familiar with animals? Is there a difference between that? So we're collecting that information. In this group, 4 people had pets. I think it was 6 did not have pets, 2 had dog, or 1 had a dog, 3 had cats. Okay, so that was again kind of the background and makeup of our participants. Thanks. For the measures that we used, again, we were looking at adolescent behavior. We developed an adolescent behavior survey that was modified based off of Glasser's work with reality or choice theory or reality therapy. There was not anything specific, so we took a school-based observation in terms of these 7 habits, and we modified it to kind of just generally speaking in any area, how do the clients self-rate and how does staff rate them on the 7 different behaviors and that we were looking at. For depressive symptoms, we used the PHQ-9, which is the Patient Health Questionnaire, 9-item survey that looks at or asks questions about various levels of depressive symptoms. And for the anxiety, we use the generalized anxiety disorder scale, which is 7 items that has various statements related to anxiety, and they self-rate kind of how often they experience those within the past 30 days. We have a sheet going around that people can sign up to receive these PowerPoints. For sake of time, I'm not going to go through every question, but essentially we have what the surveys look like. And the PHQ-9 and the GAD-7 are public domain, so those are things that you can download and use in your own practice. The adolescent behavior survey, again, was something that we adopted, so that's able to be, if you're interested in what that looks like, you can see it on the slides, or I'd be happy to share a copy with you by email as well.
Okay, so the methods, like we said before, we're going to flip this one pretty quick because we've already been over this. It's a 6-session protocol. These are the 6 habits that each of the interventions are based on. Okay, so the first session is based on listening, and what this, and you're going to have to do it again in a minute if you want to just do it now, sorry. So the therapeutic goal of the first session is to increase knowledge and awareness of emotional symptoms that are evoked through participation in self-examination. So basically we have a therapeutic goal like that, that the therapist is responsible for making sure that the activity matches. And then we have an equine goal, and this is the one that we share with the students in their journal, and that is to learn to listen to horses' verbal and non-verbal communication and also be aware of their own presence with the horse. The activities we do, and a lot of these would be familiar to you guys, is we introduce them to walking into a horse's space through the horseman's handshake. So we have 5 participants usually. We'll have 5 horses in stalls. We'll have a handler holding the horses, and we will ask each participant to meet each horse if they're comfortable. And we sort of observe the behaviors of the horse, and we don't talk about how the horse actually interacted with that particular individual, but we do tell them signs to look for if the horse is accepting or if the horse is nervous or if the horse is not paying attention. And we just ask them to kind of monitor that feedback. And then after they've met each horse, we ask them to go stand by the stall of the horse that they'd like to work with for the 6 weeks. So far, we haven't had any problems with that. After that, we have the mental health professional read through a kind of like a script, but it's sort of like different every time we do it. We let the participants walk into the stall, but they don't stand next to the horse. They stand away from the horse, and they go through sort of a mindfulness practice of just being aware of being in the horse's space, what that feels like, what their body's feeling like in the moment. Can they relax it a little bit? And then we have them focus on the horse's breathing as they can see it, and then their own breathing, and then they walk in and they can make contact with the horse. So at that time, the horses are still being held by the professional. But it's basically all about getting them grounded, because when you see these 5 kids come in, they all live together 24/7. And so they come in, they're laughing at each other because they're trying on helmets, they're fooling around, the staff is trying to keep them quiet, the staff is coming at us, trying to tell us all about the kids, and it's very chaotic. But the second we cross that red tape into the barn, literally red tape in our barn, it's like, whew. And so we found that this is a really great way to capitalize on that and just really get them listening and understanding about building a relationship and being aware of where they are in terms of the horse. Then we go over how to halter the horse. At this point, we usually have the horse handlers still with each horse. They're not with them individually yet. And then we just go over grooming and how horses use grooming to make friends and We call it grooming for connection because we're not trying to get them clean, and we just kind of let them figure that out. So when we process, we talk about the experience, what they were aware of in themselves, what they were aware of in the horses, and what they think of their horse choice so far. So that's the first week. Some of the feedback that we've gotten from the first week so far, I threw these in there, did a couple of copies of the journal, taking out any information if they use their horse's name. But I mean, this is just a really neat concept to be able to see this. Some of these kids, they're 15, 16, 17. A lot of them have legal issues related to drug use and other things. But I feel like almost the way they talk about their horses is just like kind of gleeful and childlike, and it sort of like captures that piece of them that I think they don't always express to others. And so some of the feedback that we got here is I was nervous at first. I didn't know that the horse was going to be so calm. Go through a little bit more, and at the end he wrote that the horse was a rock star. And I just like the fact that he even drew a picture of the horse. So right now, like I said, we haven't analyzed any of this feedback, but it's really helpful for us to see like what they're getting out of each session. Is it handling that 7 habit that we're trying to address? And, is the feedback positive, or are they not feeling safe? That's another big thing that we're looking at right now. So session 2, therapeutic goal is to learn to trust others through working with a group and then working with a horse. The equine goal, ability to lead the horse, and participation in group leadership activities. So, right now, what we do is we walk out to the field as a group. There's a mental health facilitator, the equine specialist, and the horse trainer, and then the group of kids. And we just ask them to observe the different herds. And then we just say, anytime you notice anything that's going on in the herds, like, let us know. Most of the times the horses are just eating. But this will take like half an hour sometimes because they have so much to say. And at first they say nothing. And we have to prompt them a little, well, which direction are they facing? And what are they doing with their bodies? And then all of a sudden, like, all this stuff just comes pouring out of them. And they're just, I think the cool part about being there is they're like really excited, they're engaging. They don't be like, why'd you think that, to each other? Like, they listen to each other. And so that's been one of the really encouraging, cool parts of this. And then we show them how to halter a horse again as a refresher, and then we send them out in the paddocks to get their horses paddock by paddock, so 1 at a time or 2 at a time. We talk a little bit about body language, but for the most part, we just let them figure it out. And this has been like the breakthrough week for a lot of them in terms of trust and realizing that the horse is negotiating a relationship with them. Then if we have time, we do grooming every week, but you'll notice it's on there every week. We don't always have time, but we have it in there because that's their favorite piece. So some of the feedback we've gotten from the second session, that the horses and people are not the same. Okay, that's good feedback. Me because he kept running for me, and then he just wants grass, and then I had to give him treats just for stopping running. But you see how this is a process of understanding that the horse is doing a behavior and they're relating it to their behavior in the process, and that's sort of what we're looking for. And so these might not be very scientific, but this is exactly what we're getting at through the sessions. Another one was, with horses, they're scared of you just like you when you come, just like you want to run from them. Horses are very curious because I noticed it from their ears, coming the same direction we are in case of harm. And I mean, that tells me that this person is like, they're very aware of safety, right? And they're also aware that the horse is aware of safety, and this is sort of like a bond and a way to connect. Thank you. So session 3 is based on supporting. Therapeutic goal of this session is to learn and practice skills by staying connected to others. Equine goal is to demonstrate supportive role and partnership with the horse, and try to earn the horse's confidence while you try harder and harder activities. So the activities we do is first we allow them to just lead around the ring and get used to stopping and turning and being with their horse. And then we do some drill team leading. So they have to work as a group. We just did this one this week with our 3rd cohort. And they have to try to stay with each other across the ring. And then the better they do, the more things we try. So this week we had a really great group, and we were, coming across the diagonal and crisscrossing and turning in groups and meeting on the center line and then separating. So they had a lot of fun. We actually had 2 kids that are in ROTC at their schools back home, and so they were so excited to be doing drill team. And then we had a little bit of extra time, so we tried doing it to music and speeding up and slowing down the horses and kind of staying with the rhythm. So we play around with this one a little bit depending on the group. We've had some groups that all we can do is try to stay across from each other and just maintain that balance. And they have a really hard time looking away from the horse and looking across at the person. So, we're still trying to figure out the best way to do this, so we try a little bit of different stuff. But this week has been the week where people really open up in the processing after and talk about what it's like to work as a group and what other people's horses are like, although their main focus is always their horse. We don't. We have, but the equine specialist and the horse trainer are in there. And we have 2 other staff on property in case we need them. And we have the mental health professional who could always, go get them, or one of us could. So we haven't had to use them for this one. Okay, so some of the feedback from this one was my horse was comfortable with me, listens to me, and follows my moves for him to move. And again, these words don't sound profound, but when you really think of where they're coming from and what that means, I mean, this is like really profound. I like this one. I was a very good leader, but nervous at the same time. Leading and not being led, especially if it was a big animal. So there's a lot in that little sentence, right? Okay, so the 4th session, the habit we're trying to work on is encouraging. So the therapeutic goal is to demonstrate empathy and encouragement as others attempt tasks in front of you. The equine goal is leading participant horse teams through an obstacle course. So what we do is we just bring them out to our area with all the obstacles. We've had to do this one inside a couple of times too. So we'll just bring them wherever they are, and we'll either set it up in the barn aisle or in the ring, depending on the weather. And then we as they set up 3 different obstacles each, we hand them a sticky note, and we say, okay, write something that's an obstacle for you in your treatment right now. So they'll go out and they'll stick it on whatever obstacle they want. Then we let them, we go out in the paddocks, get the horses, bring them in, and then we let them choose what 3 obstacles they want to get their horse to go over. So we don't tell them they have to pick the one that has their sticky note on it. We just let them choose. And then they watch each other go through the process. And then usually if we have a good group, we've had one group we didn't incorporate this, but our goal is to have them say something positive to their peers as they finish. And then they turn their horse back out and the next person goes in. Okay, so some of the feedback that we've gotten from this one is my horse did good. And he trusts me taking them through the obstacle. Strangely, this is the one session that we've gotten the least amount of journal responses for, and I don't know if there's just a lot of internal processing going on or whatever happens that week in the program. But we get a lot of feedback during the group processing of this piece. And I would say that 9 times out of 10, people pick an obstacle that they put a sticky note on, but we always get somebody in the group who either forgot about it or decided they wanted to go over other people's obstacles. But we try to talk about why they chose the obstacles they did and how was it to overcome those obstacles. So kind of like most of us do in this. Thank you. Okay, so session 5 is built on respect and respecting others. So we learn the therapeutic goal is to learn effective coping skills for overcoming adversity within a group, respecting decisions and views of others. So the equine goal is to learn correct, safe way to rope halter and then engage in the circling activity, which is part of Pirelli's games. So we go through and we talk just very briefly about what the games entail, and we practice a friendly game first, and then we have them go one at a time and try the circle game. So most of our horses are Pirelli certified horses and are pretty good at this, although our minis are not. So there's a little bit of a discrepancy in how good the horses are at this, but it really shows the kids that it's them doing the work, and it's not that the horses are just really good. And believe me, our Pirelli horses aren't always perfect in this exercise either. So the activity is the demonstration of pressure. So we go through the friendly game first on a barrel, and then with their horse. And then they go one at a time, and they just attempt getting the horse to go around them in both directions. And when we have time, we come in and groom after that. And feedback that we've gotten from session 5 so far is that I think it looked easy, but then it was hard. Because I think I need to learn communication better to work with the horses and be more comfortable. And that actually came from someone who every week was like, oh, my horse loves me. He's so happy whenever I come in the barn. He knows I'm here. So this was like really interesting feedback from that particular individual, because every week we're upping the ante a little, and it's a little bit harder. And we're challenging their leadership, and we're also challenging their communication and awareness and things like that. And then the sixth session, this is the last week that we have them, is negotiating differences. So the therapeutic goal of this session is to learn to problem solve difficult situations while finding a common resolution with a desired outcome. The equine goal is facilitate positive join-up activity with the horse and successful grooming of the horse. So what we do is we pull 2 horses out of the herd that they have never worked with before. So we have a herd of 10, I think, right now. So there's 5 in the program. We'll pick 2 that aren't currently in the program that they've never interacted with, and we let them loose in the arena. And we stand in there with them. We set up a few obstacles. Usually there's a box and maybe a cavaletti and some poles, maybe some cones. And we ask them to work as a team to get those 2 horses over 2 of the obstacles. They're not allowed to touch the horses. They can talk to the horses and talk to each other most of the time. We had one time where we had to ask everyone to stop talking. I forget what happened, but it probably wasn't good. And they had to do it silently. And so this always kind of comes out the same, with everyone just standing around for about 10, 15 minutes, and then one person jumping in and trying to do stuff all by themselves. But eventually, so far in our first 2 groups, because our third one hasn't done this yet, they have worked as a group and successfully gotten 2 horses that they don't know through 2 obstacles, no halter, no lead rope, just using group teamwork and body language and communication. So I have to say, the first time we did this, I was a little nervous. And I kept looking at the other, horse professional in the ring with me and being like, we're good, right? We're good, right? And it was good. It was good. I just had to take deep breaths. But I can just imagine how that felt for the adolescent with no horse experience, right? So I kind of felt like I was in their shoes a little. And then at the end, we allow them to take their own horses out of the paddock and groom them and say goodbye and thank you. Yeah, there's no feedback yet from session 6, so.
So as we move into kind of the results section, those were the 6 sessions that we integrated into, and we worked closely with the adolescent treatment program to ensure that they were in line with the type of work that they're doing at their center, right? And one important thing that we feel about this, the integration of EFP and adolescent treatment, is it takes their treatment as usual at the residential program and tries to enhance it. And if we had something completely unique or not unrelated, that'd be more difficult. So we really got some good feedback from the counseling staff and the directors over at the residential program to look at our sessions and determine, do these match with the types of skill building and types of activities that we're doing on site at the residential program, in order to really be able to make a statement or kind of enhance what they're learning about. Looking back at our research questions, just a kind of refresher before we get into the results. Again, we're looking at, are there changes in the behavior across the 7 healthy habits? Right? Do we notice an increase or decrease in terms of how often they demonstrate those healthy behaviors? So what we're looking for is an increase in those behaviors as opposed to a decrease. The second question was looking at depressive symptoms. So on the scores of the PHQ-9 around the different items associated with depression or depressive symptoms, was there a reduction or an increase in those depressive symptoms? Ideally, we're looking at a reduction, that we want them to feel, demonstrate, or recognize those symptoms less after our intervention, after treatment, as opposed to increasing those. And similar for the symptoms of anxiety. So for the generalized anxiety disorder scale, we're looking at, is there a reduction in expression of anxious symptoms or internalization of those anxious symptoms? Thank you. And what we found was, for the behaviors, there was significant, statistically and clinical significant increase in the demonstration of those behaviors. Right? So these sessions were able to, at the end of the 6 sessions, in was it, I think 2 weeks after that when we did our follow-up report, we're looking at pretty significant changes in terms of self-identified and staff-identified changes along those 7 behaviors. The survey itself ranges 1 to 4, so 4 being the top. So you can notice through these lines, the second line down is 4. So a lot of them end up creeping up on the always demonstrating or feeling these behaviors, right? I always feel like I am respecting, I always feel like I can negotiate differences, et cetera, as compared to the pretest, which they felt that either not at all or not often or not very often, right? For psychological symptoms, the PHQ-9 has a top score of 27. So your left is the PHQ-9 if you can't read the bottom. The pretest, the first administration of the PHQ-9 that we did, only reached an average of a little bit over 6. So that's not that high. There was a statistical significant difference between pre and post. However, I'm cautious to say that it would be clinically significant, right? Because their depressive symptoms weren't expressed highly that much to begin with. However, in terms of a trend, it is trending down, meaning that it's reducing the self-report of depressive symptoms, which is something that we are mindful of as we go forward, as we continue the program, get more participants. We may start seeing a little bit more differentiation. With more numbers, will that spread increase or will it come kind of closer together? That'll really help us determine, is this intervention something that is beneficial in terms of helping with depressive symptoms or not? And on the right-hand side is the anxiety. The top score for the GAD-7 is 21. This one starts at, or the mean was 12 point, basically between 12 and 13. So that's a little bit closer in terms of a high rating. That would be moderate anxiety based on the scoring protocol. And after a post-test, it dropped down to 4. So we're confident in that the intervention, again, in terms of a trend, definitely shows the trend of reduction of anxious symptoms. From a clinically significant perspective, meaning in real world, does it actually have an effect that can be seen? I'm more optimistic about this, that individuals have anxiety, and partially because they're in a residential program, it may be tied to the treatment, it may be tied to their current situation. However, after 6 weeks of participating in equine facilitated psychotherapy, as well as their standard treatment, we're able to see a pretty good or pretty drastic reduction of the expression of anxiety or their self-report in terms of their anxious symptoms.
Okay. So any good research study always talks about their limitations, and we had a few. So basically, all of our quantitative data right now, all 3 of them, right? Yeah, are self-report instruments, and we're engaging with clients who may be resistant to treatment, especially when they're doing the pre-test because they're forced into treatment. So having some more feedback from staff and maybe parents is something that we may incorporate into the future. Receiving multiple treatment modalities at the same time. I mean, they're getting individual therapy, group cohesion activities, all that sort of stuff while they're in treatment at the same time as doing the EFP program. We do have a small sample size. We're working on that. We're currently in our 3rd cohort, so we're just trucking on and trying to get more research and more results in. And we have a little bit of difficulty with accessing this population for follow-ups. Now, if they are still in treatment at the Adolescent Residential Center, we can go in and do follow-up assessments. But if they're discharged within that time frame, it may be a little hard to follow up with them because they come from all different areas. They're not usually local. And we don't have a control group right now, so we're not. There's usually 10 people in the program at the same time? Yeah, there's usually 10 people currently inpatient in the program at the same time, and so right now we're not taking any quantitative assessments on the ones who are not participating in the program. So, sure.
And the reason why the control group, again, this started kind of as a pilot study, getting things going. We're looking for external funding to be able to expand our program to do a little bit more of the research side. The benefit of, and really the thrust of using a control group is to be able to get at not just does this program help, but how does it help in comparison to treatment as usual. So you have individuals in an adolescent treatment program. Again, I feel confident about what we're doing, but it's hard to make a statement that we are outperforming or we are doing better, or the adolescents are doing better after engaging in our intervention than those that do not. So the other 5 that are still on site, how are they progressing in terms of the different behaviors, anxiety, and depressive symptoms? Is treatment as usual keeping pace with our integrated program? Or by adding the horses, are we actually enhancing, which is the overall kind of thing that we want to look at, are we improving upon outcomes? Or is it just a fun activity, a different way of engaging the participants, but it doesn't add, in terms of clinical outcomes, it doesn't add much. So that's one thing that, as we develop this program, as we grow it, that we definitely want to be looking at is what is that difference between standard, I call it treatment as usual, the standard treatment and the integrated treatment. So good results. We're very happy with the results, but we're cautious in terms of the interpretation of them.
Which is exactly what we have on the next slide, is the future directions and what we want to go through, is try to incorporate some non-self-assessment measures in terms of staff and then parents if they're discharged, adding a control group, larger sample size, some follow-up questionnaires beyond the 2 weeks and or assessments over a period of time. And some of the things that we'd like to measure are recidivism and behaviors, delinquent behaviors and positive behaviors as well. So, do you want a clippity clip? So some of the implications for the EAAT field are we're trying to get more quantitative evidence that adding EFP into addictions treatment for adolescents influences outcomes positively. We're also trying to prove that a protocol with a theory interwoven in is doable and is a really good way to replicate the same kind of treatment over time and make it eventually into an evidence-based practice. And efficacy-based research to support the growth of programs like this and other programs, so that if you want to develop a program like this in your center, hopefully we'll get some research out on this that you can present to your center and to your board and say, look, this is what they found. They've had really positive results. They've been measuring it over time. Let's present this and see if we can get some funding and support. So that's basically it. So we wanted to make sure we had some time, which we did pretty good, to open it up for questions, comments, concerns, suggestions. Okay.
Three questions. When in the residential process did they begin to participate in your program? Were they duly diagnosed? Did they come in or start new medication when they came to the system?
Okay, so the 3 questions were, just for the recording,
When in the residential time frame did they begin with you? Had they been in the residential facility for a period of time, or did they start right in the gate?
so the first question is when in their program, in terms of being the intake, if you will, to the residential program, at what point did they start our research? Are they duly diagnosed? Are there any co-occurring mental health disorders? And then the third question was, did they start any new medications or change the medications? The first question is, depends on the cohort. The first cohort we received, or that was referred to participate, they had been in the program, I want to say, about 2 months. It's a 3 to 4 month program. It depends on improvement. They have some internal measures that they look at in terms of when discharge is. So it's not a X amount of time set for everybody. So about 2 months. The second cohort, and this was part of the difficulty working with one treatment program that has 10 participants in the treatment program. We're doing a cohort of 5. If they're there for 6 months, we're waiting 5 months or whatever the subtraction is on that. We're waiting a long time for another cohort to fill up. Coincidentally, it ended up that as that first cohort ended, there was another group coming in. Their second cohort was actually earlier on in treatment. I want to say within the first month of their treatment. So there's differences on that side in terms of when they began. In our third cohort, there's actually a lot of turnover, some graduations, some discharges, administrative discharges. So this third cohort is more similar to the second in that they're just starting the program. That's definitely something that we would want to look at in terms of differences in terms of timing. Co-occurring disorders, we did not assess for that. The data demographic data we collected that type of information would have required us to gather their health records, because self-report, I'm going to say with everybody, but especially for adolescents, is probably not reliable in terms of diagnosis. And we chose at that point not to reach out and try to get other data directly from the health center. We're just doing the self-report data as well as the staff feedback in terms of their behaviors at pre-test and post-test. And that goes, same answer for that in terms of medication changes. Yep.
Somebody over there was before me.
I have 2 questions.
Okay.
The first is, how is the program funded? And second, do you have the participants, did anyone express an interest in riding actually as a follow-on once they did groundwork?
So the first question was, how is the program funded? Second question is, for those that participated, did anyone express an interest or desire to ride instead of just doing groundwork? I'll answer the first one. I'll let you answer the second one. Funding, it's a mix. I have a startup fund for the first couple of years of my appointment as an assistant professor. So being able to draw from those monies, based on the relationships that we formed with Rockinghorse Ranch, or ECU has formed Rockinghorse Ranch and the Adolescent Treatment Program, it's worked out where it's, I don't say minimal cost, but we are paying Rockinghorse Ranch for the services, the time, the staff, which includes the care for the horse within that charge, as well as the therapist. So we don't have to, it's basically contracting out that service, and we're providing the salaries or the money for both of those things. And for the referral, this was something that's a mutual benefit to the adolescent program as well as to our research. So there's no other required funding for the participants, if you will, beyond just creating the service and the time, paying for the time that it's played out. And we've also had individuals that make donations to Rockinghorse Ranch be able to identify this money can go towards programs like this. So we've been able to complement our funding. Part of why we have our third cohort is because of some of that offset funding that has come in through private donations. And we're currently seeking external grants, both foundation as well as non-government entities, to provide funding for allowing us to go a little bit bigger, be able to get a wider net, include multiple cohorts at the same time, and other adolescent programs. Again, thinking residential, longer term care than traditional outpatient. We run into those blocks of, we hit a 6-month gap because there's no new clients coming in. So we're trying to expand that as well. That's going to take, we need the funding before we can start reaching into that. And then the second question, I'll let Cheryl answer.
Yeah, the second question was, do they ever ask to ride? And yes, they do, and we make it very clear, that that's not part of the communication right now, but, we always tell them to look into resources in their areas when they go home. So yes, pretty much 90% of them ask us that.
And there's nothing that prohibits these individuals from coming back to Rocking Horse separately and engaging in the different services that they offer that are not part of our research, but are the just general services offered through there. Again, if feasible, if parents are engaged, et cetera.
One of the problems with this type of research is the objective measures. And one of the goals that you noted was to use or to find some non-self-report measures of outcome. What are you considering?
So the question was, with the subjectiveness of self-report, what objective measures are we looking at? Is that a good summary? There are a few out there, one of which is the GAIN, the Global Assessment of Individualized Needs. That is a more holistic biopsychosocial assessment, but it gets into both addiction, mental health, as well as other psychosocial concerns. So legal, medical, social connectedness, and I think there's one other I can't remember. But that one has been psychometrically more psychometrically sound than other addiction-based holistic assessments, like the Addiction Severity Index was our gold standard. There's a lot of concerns about their composite scores. The GAIN has kind of become a new standard. It's not at the level of research that's been done to really cement it as our new gold standard, but it's moving that direction. So that's one potential. And then also looking at both the psychosocial, psychological, et cetera, but really wanting to find and integrate objective measures for the interaction with the horse and being able to tease and carve that out as its own. And we've had some communication with individuals that have done behavioral observation coding and have created a good coding scheme for direct observation of the interaction and being able to code it in terms of what that means related to our the objectives that we're looking at.
Any physiological measures?
Not for this study. We have worked on other studies, both my work with canines, doing mindfulness, as well as in the future, actually near future, we're going to be looking at doing heart rate variability. We also use skin conductance, which wasn't as strong as a measure, but heart rate variability is one of the physiological measures that we're looking at for the individual, and if we can get a good team, when we get, thank you, positive, when we get a strong team, research team, being able to look at physiological, maybe even neurochemical changes for the horse or to the animal involved. So we can look at not only are there physiological changes for the individual, but what are the partner in the therapy, the horse, what are some of the changes within them? And is there some sort of benefit on that side?
With it being self-reporting, how do you account for, or have you encountered this yet with ESL, or just language barriers or understanding of the words if they have a different disability, learning disability, or something like that? And then the second part of that is, are you giving the test the first day they come, and then the post-test is the day that they are leaving, or does the facility administer that prior to them coming to your site?
So the first question was, how do we address potential language or reading comprehension barriers to the self-report data collection? Basically, we check in. Part of it is when we go over as adolescents, their parents have to sign the consent for research, but we also offer an assent, meaning the participant, while their parent says, yes, I consent for them to participate, we want to make sure that they assent, that they agree to participate as well. And that is, if any of you are familiar with the IRB forms, a nice 4-page, written in a way appropriate for the age group. But as we're going through that and reading through that, we have to ensure that they comprehend what's being asked of them. So that's our first kind of litmus test of, are there any potential barriers in terms of reading or comprehension? We have not run into English as a second language issue. It's just by the nature of the participants that we've had. And then as we go through, obviously, what they'll be doing is more concrete, if you will, than psychological symptoms and what those might mean and how they are interpreted. So we offer to read through and we actually give examples of what these symptoms look like as a context for how they answer those. So it's not perfect, but we try to ensure that they're able to read and comprehend the words, and they're also able to understand the concept of the 9 or 7 items on those scales. Okay. What was the second question?
Where do they take it? Is it
Okay.
administered at the site or at your location?
So the second question was, the pre-test is administered on site. Where is the second or the post-test follow-up data? Where is that collected? We collect that information as a research team at the site. So we go there. We don't have the staff collect it, but they're not coming for a separate visit just to do that.
Thank you so much for this. This is wonderful information, but somewhere along the line, the sign up for your PowerPoint has not reached us. Okay, sorry.
That's all right. So the question is, where is that form? Let me bounce over here and I'll bounce back over there. Let's go in the back.
I'm sorry, I forgot. Did you guys say that the participants got the same words for the first 5 sessions?
Yes. Yeah. So the question was, do the participants use the same horse for all sessions? Yes, they're connected to the same horse. Once they choose through that process during session 1, they remain with that horse. The 6th session, we switch it up and integrate different horses. I think we have time for 2 more questions. There's a little bit of noise. The question was, because it's only 5 participants out of 10, how are those 5 chosen? Okay. We relied on the staff at the center to determine what was appropriate for them. One of the difficult parts is they obviously, as part of adolescent treatment, token economy, positive reinforcement techniques are used. A lot of times that includes rewards, if you will, for certain behavior. Participation in our project, initially, the staff was seeing it as a reward. Therefore, it was those that had earned the right to do a at-home visit. So basically, if they earned the right to go home for the weekend through whatever metric they used, that was associated with their ability to participate. And I think it was 8 out of the 10 at the time were able to. Then it was staff choice. So not a random assignment. Because of the structure that they have in place, we couldn't offer the program to everyone, as it may interfere with the kind of goals of the residential program, not rewarding someone for negative behavior, et cetera. Okay. Let's do one more, and then Cheryl and I will be available. We'll let the next group come in and get set up.
In the research for the individuals that you have in, the adolescents, do you delve into the family history that has part of the research?
So the question was, for those that participated, did we get into family history? No. We looked at just pre and post symptoms along these 3 behaviors. That would be, as we expand, we're going to start looking at different measures that are more holistic, and family and social and family connectedness are part of that bigger assessment. So no, but will be integrated as we go forward. Good. I know there's a few more hands. I apologize. I want to make sure the next presenters have time to set up. Thank you all so much for coming.